start with the second talk by me on screening and treatment.
So now we welcome Dr. Anubhav Goyal for the second talk, Screening and Treatment in Retinopathy of Prematurity. He is a very passionate person about ROP. So Anubhav, please.
Slides, please. So good morning, everyone, and thank you, KSOS, for giving this opportunity. Mine is on screening and treatment in ROP. So as we all know, it's a vasoproliferative disorder of retina in premature infants. And if you see, 1 out of 820 babies are getting blind due to ROP. Even a single child getting blind is a lifelong pain for not only for child, but for parents and whole community. So timely screening and timely treatment is at most necessary. So screening, because screening can prevent this disease to get the eyes blind, and it has a lot of medico-legal implications. As you can see, there are a lot of compensation has been honored by a court of law for failing ROP or missing ROP, which can be till 3 crores in India, which has been already done. So for Indian screening guidelines, as Dr. Divya has told, it is 1, 2, 3, 4 rule. It's a golden rule. Screen before 1 month of premature birth, screen less than 2,000 grams of the baby, and below 34 weeks of gestation, which is very necessary. Earlier, this babies you can screen a little bit earlier, like 2 weeks after the birth. So golden rule is 1, 2, 3, 4. We need an indirect and 28D or 20D lens, dilating ROP drops, paracane, and vector and speculum to screen the babies. And preferably, I prefer to screen in the NICUs under the care of neonatologists and the nursing staff who are well trained. You can all discharge and stable babies, you can screen in OPD, but most of the babies are usually sick and needs ventilator. So better to screen in most of these sick babies in ICU itself. How to make ROP drops? So ROP drops is exactly the half concentration of normal adult T plus drops. So if you dilute it with normal saline or CMC in 1:1 ratio, it will be nearly ROP drops, and you can use it in, you need not a special ROP drops to use it. Baby should be nicely warmed, keep warm and mummified during this treatment, because babies are very vulnerable for hypothermia during that time. And eye should be properly dilated for a proper screening. There are a lot of imaging things like RETCam, NEO, Optos, and smartphone imaging for ROP. These are comparative images of the smartphone, NEO, and Optos. Smartphone, yes, it has a limited field of view. And comparative image of 20D, 28D, and 40D by smartphone, Optos, and NEO. That you can see the field of view. If you see, you can easily screen from disc to periphery by NEO camera with a good field of view. Smartphone also can give you reasonably good images with limited field of view, but yes, you can screen nicely and counsel the parents. And the smartphone can also see very rare other diseases also in the neonates, which can be seen after the birth. So counseling parents and counseling neonatologists and keeping them in the loop, explaining them every time all the details clearly is very important. With imaging, it's the best. Because if they don't trust you, you will not going to succeed this preventable blindness. Always use some proper documentation forms for documentation, and you can also obviously follow up these things. So next is treatment. Treatment consists of, way back in 1980, it was ROP, which showed the importance of cryotherapy. Then in 2000, ETROP shows the importance of laser in ROP. And in 2010, then anti-VEGF came. It's a revolution of in ROP with this treatment, and shows the importance of bevacizumab. You can easily see the amount of unfavorable anatomical outcome has improved from cryo-ROP to beat ROP, and hardly any baby was left with unfavorable outcomes. It is this beat ROP which has shown that anti-VEGF is better for zone 1 and laser is better for zone 2 treatment. And ETROP gives actual treatment classification for ROP, whom to treat and whom to observe. So now anti-VEGF era is there. There are a lot of anti-VEGF which has been used in ROP, like bevacizumab, ranibizumab, and Eylea. A lot of publications are there on it. And if you see, our Anand sir has already published an article which has shown that a lot of studies, Asian population studies, shown that zone 1 ROP and AP ROP needs and works well with anti-VEGF rather than laser in zone 1. And for zone 2, both laser injection works same. But a combination of anti-VEGF and laser treatment for injection followed by laser is now the practice pattern in India for type 1 ROP and AP ROP and zone 1 ROP. So as recurrences of anti-VEGF is varying, And bevacizumab gives a very long window period for improvement in vascularization, and ranibizumab is much below than this. So ranibizumab shows recurrence after 7.7 weeks, and bevacizumab can take 12 or more weeks for recurrence. So it's the best drug, even now in ROP. A meta-analysis shows that laser shows least recurrences as compared to anti-VEGF. And if you compare that, bevacizumab has the best result in recurrence. It delays our recurrence. Second comes aflibercept, and least is ranibizumab. Ranibizumab recurrence is much earlier. And beat ROP has already shown recurrence after bevacizumab will take more than 16 weeks. So it's a well-known thing. Anti-VEGF is good in refractive profile also, because laser cause induced myopia, which is not seen with anti-VEGF. Anti-VEGF, what earlier understanding was, you give one anti-VEGF, and if recurrence is there, give laser. But now the slowly understanding is changing. You can give more than one anti-VEGF. Search paper shows that you can give 2 doses as early as 4 weeks interval, and can give maximum 3 injections in 6 months of treatment. And doctors says 67% of 8 doctors says in a survey that you can give both eyes injection at the same time, same day. So anti-VEGF, Avastin and ranibizumab are the 2 preferred anti-VEGF in ROP. Bevacizumab shows it's a well taken treatment for treatment of ROP, but not approved. Even the Wild shows it is not for intravitreal use. DGCI approved ranibizumab, both Excentrix and Resumab. Most of them are using Excentrix and Resumab, but yes, a lot of us are still using bevacizumab. So I prefer, for zone 1 ROP, I still prefer injection followed by rescue laser without waiting for recurrence. Once the zone 2 posterior vascularizes, I don't wait for especially AROP or half zone or zone 1 ROP. Surgical treatment, Dr. Divya Balakrishnan Madam will be covering for stage 4 and stage 5. So this is how the laser is given with this, without any skip areas, with near confluent burns from the ridge till the far periphery. And this is how it's a case, another case example where zone 1 hybrid ROP was there with plus disease and ridge encroaching near the fovea in both the eyes, which initially treated with injection, ranibizumab, but recurrence happened after 3 to 4 weeks, for which laser was given. This is a very good thing, very good new update, which is called as peripheral avascular retina, which has come up after the advent of anti-VEGF, which is very important to consider, because if you leave 2 disc diameter of PAR, and if it is seen after 65 weeks of postmenstrual age, then it can cause a lot of retinal holes, retinal breaks, RD, and lattice degeneration, which can be a serious problem in later also. This is an example showing right eye. If you can see very clearly, there's 2 holes with a shallow SRF pocket in the avascular retina, which was seen in a 2-year baby, which we lasered, and the left eye was having a macular defect, which was also lasered. So timely treatment, even in patients seen PAR, is very important. Laser is given. This is how the laser and anti-VEGF injection is given in ROP. You can give in NICU. I prefer to give in NICU because most of the babies are very sick and very premature. So it's now unlike adult injections. You have to use thinnest needle, take it vertically down, half length inside, just inject and come out. Don't try to see the needle inside. Should not direct towards the disc because the lens is bigger and you might damage the lens. That's all is needed. After injection, you might see clouding of cornea, which is a sign that something has gone in the vitreous cavity. So we are screening nearly 19 to 20 NICUs every week in Kachin and around with the initiative of CSR. We have a mobile van. We have screened nearly 16,000 babies since in last 10 years and lost 10 babies. Red eye reflex is a fallacy, because by the time you lose the red eye, red reflex, baby is already blind with stage 5. So termination is on fully vascularized retina. We have trained a lot of fellows. And still going on. This is a promotion education poster which we are giving. So the overall goal of ROP management is to prevent retinal detachment, reduce incidence of subsequent blindness, and promote optimized visual outcomes. Early screening and timely treatment is a goal for preventing ROP that we have to keep in mind. Thank you.
Thank you, Anubhav, for that wonderful talk on the screening and treatment. I think it is very important to remember that 1, 2, 3, 4, the golden rule, and which everybody should remember and follow. And so your preferred injection is bevacizumab?
I still prefer bevacizumab, especially for half zone or zone 1. We are taking it very carefully to NICUs and maintaining cold chain. I am still not using ranibizumab a lot.
Okay, Anand sir is also here. Sir, what does your take? So I think only thing that because the recurrence can be little late, so maybe that a longer need of follow-up should be there.
For especially half zone and zone 1, we will get a lot of window for the vessels to vascularize. Otherwise, if we have to laser just one zone, one is vascularized, then it is again a trauma for the baby. A lot of area will get scarred.
Okay.